Is it audible now?
It's audible.
Is it audible now? Okay. So, okay, sorry for the disturbance. I will again start again. So, I thought that my connection is lost at here only. I'm explaining this chart. Is it correct?
Yes.
Okay. So, okay. Actually, these are the main cytokines. I think that everyone understand this one. Okay, I will go ahead. And here, CD4 T helper cell lineage, they are dividing into TH1, TH2, TH17. Already I have told. And one more T cell belong to CD4 is regulatory T cells. Okay. So, TH1 mainly involved in fighting with the intracellular pathogens. Okay. And we have the upregulation of interferon gamma. So, TH2 fighting with the extracellular pathogens, and it's involved in the production of IL-4/5/13, and the TH17 cells is mainly involved in the extracellular pathogen and fungi. Okay, and is implicated in autoimmune disorder. So this everything is, you can ask this MCQ, which are the following CD4 cell is involved in autoimmune process. Okay, it's TH17 cell. Okay, 17 subtype of CD4 T cells. And it's involved in the production of IL interleukin 17. So mnemonic is 1717. The TH17 cell will involve in the production of interleukin 17. Okay, so three main important MCQs of TH14 is, one is fungi, mainly involved in fungi and more frequently implicated in autoimmune disorders, and involved in the chronic inflammatory states. Okay, and it mainly involved in the production of IL-17, sorry, interleukin 17. So the next one is the regulatory T cells. The regulatory T cells is another class of CD4 helper T cell, essential for the development of memory and tolerance to self-antigens. Okay, and they produce potent anti-inflammatory cytokines like IL-10 and TGF-beta. So, okay, so the same IL-10 is also produced by another cell, which I have told earlier. Okay, that is macrophage cell. The macrophage M2 also producing IL-10 and TGF-beta. So next, another type of cell we are going to see CD4 we finished. Next we go to CD8. Okay, the CD8 type of C cell is mainly for virus, okay, virus destructions. Okay, and they produce in the cytokines called interferon gamma. Okay, so the interferon gamma is produced by the CD8. Okay, CD8 cytotoxic T cell. Okay, the CD4 is called helper cell and the CD8 is called cytotoxic T cell. So, and another MCQ, what is it called? So these are the adaptive T cell dependent inflammatory response is dampened by the following factors. All of the factors dampening the inflammatory response, except like that the question they will ask. So number one is, what are the things that dampening is? One is general anesthesia, number two is surgical stress, number three is blood transfusion, four is hypothermia, and five is hyperglycemia, and six is postoperative pain. Okay, so these are the things dampening the T cell inflammatory response. Okay, and one more study they are telling that they are seeing this T cell response in case of benign disease and malignant diseases. So there is post-operative, after doing surgery of breast, fibroadenoma or malignancy, invasive malignancies, there is no change in the T cell profile exhibited in patient with the fibroadenoma group. Okay, so no change in the T cell profile in fibroadenoma group, but there is a in case of invasive breast cancer group exhibited increase in regulatory type of T cells. Okay, so that they're telling that regulatory T cells increase at 72 hours post-operatively. Okay, they correlated with the following factors. So large tumor size, HER2 positivity, and a decrease in the length of the disease-free survival. So regulatory T cells. So they are asking a question like, which of the following factors is involved in the regulatory T cell increasement? Okay, except like they can ask, one is large tumor size, and another one is HER2 positivity, and another one is a decrease in the length of the disease-free survival. Okay, these are the points. Okay, and again they're telling that, so low burden of TH1 cells. Here they told regulatory T cells, and here they're telling that TH type 1 helper cells. TH1 cells was correlated with the greater tumor burden and the HER2 positivity. Okay. So just remember this regulatory T cells. There is an increase in the regulatory T cells 72 hours after post-operatively is related with the correlated with the large tumor size, HER2 positivity, and a decrease in the length of the disease-free survival. That is, it means that it is bad. Okay, and B cell. So B cell. So B cell, what is happening that the B cell is undergoing a process called VDJ recombination. No need to go in depth. Just remember the VDJ recombination will undergo with the B cell. After VDJ recombination, the B cell will go to the another process called pro B cell, pre B cell, immature B cell state. Then it will go to the spleen. Okay, after that it will become the mature. Okay, either navy, follicular, or marginal zone B cell. Okay, and where the maturation of B cell is happening, that is an MCQ, that will happen in the spleen. Okay, that maturation of B cell will happen in the spleen. So there are two types of cells. I told you that navy follicular B cell and marginal zone B cell. Okay, so the marginal zone B cell, its function in the spleen as the first line of defense against blood-borne invaders. Okay, and it is independent of T cell. There is no help of T cell needed for this marginal zone B cell, and it produces soluble IgM. Okay, we already know the immunoglobulins are produced by the B cells. Okay, this all marginal zone B cells is mainly function in the spleen as a function first line, independent of T cells, and it produces soluble IgM during the early stage of infection. And is a naive follicular B cell. Number second, the naive follicular B cell can found within the lymph node and the circulating B cell. The molecular zone B cell is found in the spleen, but the naive follicular B cell is found in the lymph node and the circulating B cell, and their activation is T cell dependent. Opposite. Okay. B cell marginal zone B cells opposite is navy follicular B cells. Okay, and it is also involved in the production of IgG-AE. Okay, this is about the adaptive immunity. Then we'll go to the innate immunity. So before we go into innate immunity, this diagram has some MCQs. Okay, these are the I already told. This side is dendritic cell. This side is T cell. Okay, and there is a co-stimulatory molecules which will interact with the T cell and the activation of T cell happening. In that, in the dendritic cells, some of the co-stimulatory molecules are present in the dendritic cells. Okay, example, dendritic cells, macrophages, B cells. This CD80, CD86 will be present in the dendritic cell macrophages B cells, and this CD275 will present in the dendritic cell macrophages B cell among the other cells also. Okay, but here you see the PDL1 and L2. Okay, PDL1 and L2 is present on the same DC, dendritic cell macrophages B cells, endothelial, epithelial, and the tumor cells also. In the tumor cells, only L1 only is present. Okay. Okay. So that's why the PDL1 antagonist is introduced in case of malignancies. Okay. Only in tumor cells, PDL1 only is available. That is MCQ. Nothing more. Okay. Not more than MCQ. And the component of the innate immunity. The innate immunity, you have physical barriers such as epithelial mucus and specific immune cells like neutrophils, dendritic cells, macrophages, natural killer cells, and cytokine proteins and the complement system. Everything comes into innate immune system. Here the MCQs, there were two theories. Okay, they are telling about the two theories. One is a self and a non-self theory. Okay, and the second one is a danger hypothesis. Matzinger's danger hypothesis. Okay, number one is self and non-self theory. Number two is Matzinger's danger hypothesis. So what is a self and non-self theory? They're explaining that it fails to explain why the body does not mount an immunological response to many non-self stimuli, such as developing fetus or the mutating cancer cell. Okay, this is self and non-self theory. And what is the danger hypothesis theory is telling that the immune system activation and propagation is more dependent on cellular damage signals than on the presence of foreign substances. So it's mainly simply that not only suppose the foreign body is present, no need to activate the immune system. Okay. Merely the presence of the foreign body will not activate the immune system. That foreign body, it should emit some dangerous signals. Then only our immune system will be activated. That is the theory given by danger hypothesis theory. Okay. Matzinger danger hypothesis told that some danger signals should be released from the foreign substance to activate the immune system. Okay. That is the Matzinger danger hypothesis. What is the danger signals? So first you'll see the danger signals which will cause cellular damage is known as danger associated molecular patterns. DAMS. That is DAMS. That DAMS is also termed as alarmins. Very, very important MCQ. Many times asked in Y second. Many times they are asked in the alarmins. Okay. So DAMS is nothing but alarm is nothing but DAMS. Okay. Danger associated molecular pattern. They will ask the alarmins is a DAM, PAM. Okay. Receptors. Okay. Alarmins is a DAM. Okay. So similar to alarmins, another danger signal specific to foreign pathogens are termed as PAMs, pathogen associated molecular patterns. Okay. These two you have to remember. And one example for the alarmine is IL-1 alpha. The IL-1 alpha is an example for alarmine. So what it can cause is it can sense chromatin damage and actively report this finding to neighboring tissues via increased IL alpha secretion. Here they're telling that nothing but you can see this diagram. Okay. I will show the alarms. So in the page number 33, 30, page number 30, here you see whenever the cell has some injury or tissue damage, it will release DAMPs. Okay, is it release DAMPs? That is alarmins. So it will go either into the nucleus via the toll-like receptors or NLRs, or it will directly cause the inflammatory response. Okay, the example for alarm is IL-1. So whenever the injury or tissue damage is happening, it will cell itself release DAMPs. It will release IL-1 alpha. This IL-1 alpha will tell the neighboring cells also, my cell is going to die. Okay, please help. Like that, it will cells. That is inflammatory response they are telling. So just remember, IL-1 alpha is the example for alarmins. So next to come to your toll-like receptors. It's the same toll-like receptors where you are seeing a toll-like TLR toll-like receptors. So toll-like receptors was initially characterized in the Drosophila melanogaster. Okay, I don't know this some fish or I don't know what is this, the Drosophila melanogaster, where the TLR was identified. Okay. Okay. So in this toll-like receptor have a one protein. It's known as a nuclear factor K beta, NFK beta. Okay, and it's mainly involved in the production of activation of B cell. Okay, similar like IL-1 is involved in the activation of T cell. Okay, so TLR having the one protein NFK beta is involved in the activation of B cell, and the cytokine IL-1 inflammatory process mediator is also involved in the production of T cell. So next we'll go to the what are the types of, there are 10 human TLRs have been identified. Okay, totally 10. Among that, what are the importance of each one? So TLR4 is have a key role in recognition of bacterial LPS, and 1, 2, 6 recognize bacterial lipoproteins. So lipopolysaccharide will be identified by 4, and 1, 2, 6 will identify lipoproteins. The same TLR4 will also recognition of HMGB1. The HMGB1 is also a DAMP which is similar to alarmins. Okay, the HMGB1 is also is also similar to alarmins only. We will deal about this later. This has separate many MCQs. HMGB1 and the heat shock protein 70. Okay, this recognized by the TLR4, and the TLR3 is recognized as a double stranded RNA, and TLR7 and 8 recognized as a single stranded RNA. Okay, so as a summary, see here, the TLR4 is involved in the recognition of bacterial LPS, HMGB1, and heat shock protein 70. MCQ. Next is 1 to 6. 1 to 6. TLR 1 to 6 recognition of bacterial lipoprotein, and TLR3 in recognition of double stranded RNA, and TLR8 is single stranded RNA. Okay, these are MCQs. So next we come to the inflammasomes. Inflammasome is having is nothing but knot-like receptors. Okay, so this knot-like receptors where we are seeing NLR. This NLR is here. Okay. It is on the cytoplasm. Okay, this knot-like receptors which is present in the cytoplasm, assembled in the cytoplasm. So what is called inflammasome? So inflammasome is these NLRs are assembled in the cytoplasm to form a key intracellular structure known as inflammasome, an essential intracellular PRR. It is nothing but a intracellular pattern recognition receptor. Okay, it recognizes some pathogens. And inflammasomes play an essential role in regulating sterile inflammation via recognition of endogenous alarmins, as well as activating the immune system response via recognition of foreign PAMs. So in this diagram you will see, so it will involve in the recognition of PAMs. This NLR will involve in the recognition of PAMs, and it also recognizes the DAMPs. So alarmins also going here. Okay, and what are the DAMPs is forming, everything is going to the NLR only. So both the DAMPs and PAMs recognized by the NLR. So your MCQ, first MCQ is the best studied NLR is NLRP3. Okay, once NLRP3 is formed, it can activate the protease caspase 1, other MCQ. So protease caspase 1 will go into the another form of next activation is activating IL-1 beta, IL-18. So by adding HMG-B1. Okay, just to see here, the NLRP3 is the main one, main inflammasome. So it activates protease caspases 1. That is another MCQ, very important MCQ. Okay, and it goes to a further process of inflammatory change. So main thing is the endogenous factors capable of priming the NLRP3 inflammasome include hypoxia. This is MCQ. Okay, hypoxia. Number 1 is hypoxia. Number 2 is complement. Number 3 is reactive oxygen species and oxidized LDL proteins and amyloids and misfolded proteins. So these are the endogenous factors which are capable of priming NLRP3 inflammasomes. Okay, so another MCQ is which of the following is involved in the sterile inflammatory process? It's inflammasomes. Remember? And then another MCQ is the role in cardiomyopathy associated sepsis. Which are the inflammasomes involved in the cardiomyopathy associated sepsis is NLRP3. This 3 is very important. Okay, NLRP3 is very important. Another MCQ. These are the possible MCQs. They could not ask other than this. Okay, whereas the MCQ is there, I already checked it. Okay, and HMG-BP1. So HMG-BP1 already told what is HMG-BP1. It's similar like alarm means it's a damp. It's an endogenous damp. Okay, HMG first MCQ. HMG-B1 is a endogenous damp and it's found in all human cell lines and it's a key mediator of lethal endotoxemia. Okay. So second one is it is involved in the process of pyroptosis. Okay, the pyroptosis, or otherwise called programmed pro-inflammatory cellular death. Okay, what is apoptosis? Apoptosis, programmed cell death. Okay, here the pyroptosis is a programmed pro-inflammatory cellular death. Okay, so what are this HMG-B1 stimulates the release of pro-inflammatory cytokines like TNF-alpha, IL-1, IL-6, and IL-18, and the MIP-1. Okay, it is also serves as a chemoattractant for macrophages and neutrophils. Okay, and it's in HMG-1 is a rapidly growing target of many molecular and clinical research, and it is involved in the process of many pathologies like sepsis, hemorrhagic shock, chronic inflammation, atherosclerosis, IBD. So many pathologies here. HMG-B1 is involved. So again, telling HMG-B1 is an endogenous damp. Okay, it's found in all human cell lines. It's a key indicator of lethal endotoxemia. And it's involved in the process of pyroptosis. And it's stimulates the pro-inflammatory cytokines like TNF-alpha, IL-1, IL-6, and IL-18, and the MIP-1. It also serves as a chemoattractant for macrophages and neutrophils. Okay, and it's involved in the many pathologies. So next, cytokines. Cytokines, we have come to the cytokines. All the cytokines is not only pro-inflammatory. The cytokine is a combination of pro-inflammatory and anti-inflammatory. Many cytokines itself having both activities. Okay, that's it, telling the complex balance between the pro-inflammatory and anti-inflammatory mediators. So where MCQ is, what are the acute pro-inflammatory response? Acute pro-inflammatory responses. What are cytokines involved in acute pro-inflammatory responses? One is TNF-alpha, IL-1, IL-6, IL-8, IL-12, and interferon gamma. Anyway, you have to remember only these are the cytokines involved in the acute pro-inflammatory responses. TNF-alpha, IL-1, IL-6, IL-8, IL-12, interferon gamma. Among these, what is the hyperacute mediators? Next MCQ is TNF-alpha and IL-1 beta. Okay. Okay, it exhibits the effect within 1 to 2 hours. Okay, 1 to 2 hours it exhibits effect. So what are the subacute fashion? Hyperacute you have seen TNF-alpha and IL-beta. What are the subacute fashion is IL-6 and IL-8. Okay, it comes in 1 to 2 hours. So you have to remember the 3 things. What is acute, what is hyperacute, what is subacute. Finish. So your acute inflammatory mediators are TNF-alpha, IL-1, IL-6, IL-8, IL-12, interferon gamma. And hyperacute is TNF-alpha and IL-beta. And subacute is IL-6 and IL-8. Okay. And next we'll come to the each and every cytokines, individual cytokines. First we have the TNF-alpha. So TNF-alpha, no need to put this particular delta, and we'll see about the source. The source first we'll see about the source, half-life, and what are the functions of each cytokine. So source, the source of the TNF-alpha is both the innate and adaptive immune cells. So many of all the cytokines will mostly come from the innate and adaptive immune cells only. No need to remember this much deep. Okay, and you see you have to remember about the half-life. It's begin at 30 minutes of the response, 30 minutes of the injury. Okay, and the half-life is half of this. Okay, 15 minutes you remember, and it will come to the peak in 1 to 2 hours. Okay, and they are telling that the TNF-alpha and IL-1, these both are the main cytokines which we see nearly in all inflammation response from sepsis and trauma to autoimmune disease. If you don't know about answer for any cytokine, you can just directly go for TNF alpha or IL-1. This may be the answer. Okay, that's why they're telling TNF alpha and IL-1 is involved in nearly all the inflammatory processes. And this TNF alpha acts via two receptors, TNF1, 2. Okay, but they're telling that soluble TNF alpha receptors. Okay, remember the soluble word. It's not insoluble. It's a soluble TNF alpha receptors modulates the function of circulating TNF alpha. Okay, so our circulating TNF alpha is modulated by our soluble TNF alpha receptors. Okay, so these are the MCQs of TNF alpha. The TNF alpha mainly source half-life. Okay, it is the main one, and the soluble, the word is important. And the IL-1 is primarily from the macrophages. Okay, primarily from the macrophages, although immune system and non-immune system cells also secrete IL-1. Okay, so along with the TNF alpha and IL-1, IL-1 is a hyperacute pro-inflammatory cytokine with a half-life of 10 minutes. So here our half-life is 10 minutes. So, but when this half-life is very small, the TNF alpha, IL-1, the half-life is very small, around 10 to 15 minutes only. So that they're telling that neither has proven to be a valuable prognosticator for injury severity or to predict development of organ dysfunction. So they are not using it as a prognostic valuable factor. Okay, TNF alpha, IL-1 and all, because the half-life is very small. This is one MCQ. Okay, it's TNF alpha and IL-1 are so brief, half-life is so brief, so they are not using as a prognosticator. And predict of development of organ dysfunction. So next thing is this I will come later actually. Finally, I will finish this one. Stable. So next we'll come to here. They're telling that this table is very important. Table 3.2 is very important. Okay, so you see they are telling that it is a partial physiological effect of induced by infusing interleukin 1 or TNF alpha into the human subject. They injected this both interleukin 1 TNF alpha into the human subject, and they are checking that what are the effects are happening. In that, the MCQs are both IL and TNF1 are also in. We have remember all of this happening in TNF1, okay, tumor necrosis factor, except increased platelet count. The platelet count is not increased in TNF. When we are injecting TNF, the platelet count only is not increasing. The rest of the things are happening. Okay, in TNF. Okay, but in IL-1, what are the things are not happening in IL? You just remember what are the things not happening. That can be asked as MCQ. So in IL-1, what are things not happening is, so hypozynkemia. Okay, the zinc level is not decreasing. Okay, in case of interleukin 1, and the coagulation cascade also not activating, and the pulmonary edema, hepatocellular injury also not happening. Okay, if you're injecting IL-1, which is happening in the TNF. Okay, once again, TNF alpha, only platelet count is not increasing. Okay, and the IL-1, hypozynkemia. Okay, activation of coagulation cascade, pulmonary edema, hepatocellular injury not happen. Okay, that's one. So next comes to your interleukin. They are telling that when you are injecting the TNF alpha into the experimental animals, it resembles like a septic shock. Okay, and interleukin 6. So interleukin 6 is secreted by same some immune cells, non-immune cells, macrophage entities. This one no need to remember. And main thing is it is a pyrogen similar to IL-1. First thing. Okay, and it immediate acute phase responses, involve production of the acute phase responses. So what are the acute phase reactions? This is many times asked MCQs. Acute phase reactions. There are CRP, complement proteins, fibrinogen, ferritin. Okay, 2C, 2F. Remember, complement, CRP, fibrinogen, ferritin. These are the acute phase proteins produced by the liver with the help of interleukin 6. Okay, so CRP elevation begin around 8 hours post injury and peak within 48 hours. Okay, as opposed to TNF alpha and IL-1. So among this, the CRP will be elevated initially with a peak within 48 hours. CRP will be elevated. Another MCQ. And next thing is the IL-6 is currently considered the most accurate prognosticator of outcome with the increased and sustained level of IL-6 directly correlating the poor prognosis. So here we saw that the IL-1 and TNF all not used for the prognosticator. The last line in the TNF, you see TNF alpha and IL-1 neither proven to be a valuable prognosticator, but IL-6 is used for the prognostication. Whenever IL-6 is increased, it indicates poor prognosis. Remember, okay. So IL-6 is also a procoagulant state. Okay, and the main thing is whenever septic shock happening, so mainly the patient in septic shock will die of the myocardial arrest. Okay, the myocardial dysfunction that accompanies septic shock is strongly mediated by IL-6. Just remember the myocardial dysfunction that accompanies septic shock strongly mediated by IL-6, and it also is anti-inflammatory effects. Okay, anti-inflammatory effects also there. It is involved in the production of this IL-10, TGF-beta, prostaglandin E2, and one more thing is called that CARS. Okay, so IL-6 also involved in the CARS, counter and compensatory anti-inflammatory response syndrome. So it is nothing but opposite to CIRS. The CIRS, the inflammatory mediators are very much increased. In the CARS, it will be very much decreased. Okay, so IL-6 is involved in these the factors. So the IL-6, once again I am telling, the IL-6 involved in the production of acute phase reactants 2C, 2F, CR2 will be in the peak yearly. So it is most accurate prognostic factor for the outcome. And it has its procoagulant state. And myocardial dysfunction is mainly because of IL-6, and it's having anti-inflammatory effect. Okay, and it involved in the production of these three mediators, and it also involved in the process of CARS. So next come to the interleukin 4. Okay, interleukin 4. So interleukin 4 is anti-inflammatory cytokine. It is secreted by the innate immune cells. Okay, and the adaptive immune cells. Both the innate immune cells also, adaptive immune cells also secrete IL-4. Okay. Okay. In adaptive immunity cells, example Th2 cells, and other cells, mast cell, basophils, eosinophils, everything they will secrete. So it mainly involved in the release of this IL-4, TGF-beta, and IL-10. Okay. So IL-1 itself is releasing IL-4. Sorry, IL-4 itself is releasing IL-4, TGF-beta, and IL-10. Okay, and this IL-4 is mainly involved in the promotion of this Th2 cell and inhibition of Th1 cell. Okay, and it also promotes humoral B-cell immunity response, and it's mainly having in CNS injuries. In CNS injuries, IL-4 plays a main role, and it's having highly neuroprotective role. Okay, just remember IL-4 has a neuroprotective role. So IL-4 is involved in the secretion of the same IL-4, TGF-beta, and IL-10, and it's promote Th2 cell and it inhibit Th1 cell, and it also involved in the B-cell immune response, and in CNS it is a neuroprotective role. So interleukin 10 is very easy. It's down regulates actually. It's down regulates the expression of pro-inflammatory TNF alpha, IL-1, IL-6. Remember, it is down regulates the inflammatory process. That means that it is mainly act as an anti-inflammatory. Okay. So it down regulates this thing, and it's up-regulating the opposite thing, ILR1 receptor antigen and TNF receptors. By up-regulating this, because of up-regulating these factors, it down regulates this TNF alpha, IL-1, and other things, and it's having both protective and injurious effects. Okay, the main MCQ in IL-10 is IL-10 plays a role in the transition from early reversible sepsis to late irreversible sepsis. Okay, which cytokines play important role in transition from the early reversible sepsis to late irreversible sepsis is IL-10. Okay, just remember this term at least. Okay, and the TGF beta. Now we go to the TGF beta. The TGF beta having its overall it is an anti-inflammatory effect. Okay, okay, it's a very anti-inflammatory effect. TGF beta is anti-inflammatory effect, and its three isoforms are present. Number one is beta 1, beta 2, beta 3. Okay, this can be assessed MCQ. Where is the beta 1%? Where is the beta 2%? Where is the beta 3%? So beta 2 will be present in the bone cartilage skin. Okay, and beta 1 and beta 2 is present in neurons and astroglial cells, and beta 3 is located in the palate and lung tissue. Okay, just remember, we have to mug up only these things. We have to mug up only, and we have to see TGF beta. It regulates the epithelial to mesenchymal transition. Number one, and it's regulate VEGF, vascular endothelial growth factor. That means it is not in the angiogenesis, and it involves the development of all T cell types within thymus, and it inhibits the survival of autoreactive T cell in the periphery. Okay, in the thymus, it is developing the T cell, and it inhibits the T cell in the periphery. So periphery, it is killing the T cell. In its thymus, it is developing the T cell. Just remember like that. And TGF beta having special one paradoxical effect. What is the paradoxical effect? Means in case of malignancy, in early malignancy, it is act as a tumor suppressor gene. But in late malignancy, it will act as a tumor promoting gene. Okay, it's not a tumor suppressant. It will enhance the tumor in late process of the tumor, because we already see it is involved in the epithelial to mesenchymal transition, which is very much important for malignancy. So TGF beta regulates the EMT. In early malignancy, it will act as a tumor suppressor. Late, it will act as the opposite. So main thing, early case, it acts as a tumor suppressor. In what phase of the cell cycle it is arrest the cell cycle? Okay, in what phase it is arresting the cell cycle is G1 phase. Okay. Just remember, that is the MCQ. TGF beta arrest the cell in the G1 phase. Okay. All of the following two, like they can ask. Next one, the complement system. Complement system, no need to, I think no need to read everything like UG. Okay. This main concept is important. Number one is the complement system will activate with three pathways: classic pathway, lectin pathway, and alternative pathway. Finally, it is going to restrict the cell. It will activation of many complements. Okay. Finally, the C5b C9 is a membrane attacking complex, MAC. Okay. If it is formed, the cell will be destroyed. Okay, the pathogen will be destroyed. So there are three pathways are there. One is classical pathway, lectin pathway, alternative pathway. So classical pathway is involved is formed with the activation of C1. Okay, mainly C1. Lectin also via C1, activating C1 only. And how they are activating, that is the MCQ. And alternative pathway will start from C3. That is different. Okay, this is MCQ. Okay. So the classical lectin pathway will start from C1, and the alternative pathway will start with the C3 activation. So these are the MCQs. Then we will see individually. So in the classical pathway, okay, the antigen antibody complex activated by either bind with the complement component C1q. I told already C1q. The C1q can also be bound by CRP, serum amyloid B. Okay, just remember. So CRP, serum amyloid B, and the antigen antibody complex. These three will bind to the C1q. That is MCQ. In the lectin pathway, okay, it will activate the C1q via the three things. It is very much important MCQ. So what are the three things that is important to activate the C1q in case of lectin pathway? Number one is mannan binding lectins. Number two is ficolins. Number three is collectins. Okay. So MFC. Okay. Mannan binding lectins, ficolins, collectins. These three are mainly responsible for lectin pathway. Okay. So another thing is they are telling that the primary function of the C5b is to initiate the formation of the membrane attacking complex. Membrane attacking complex C5b C9. So MAC is existing the two forms. No need. In its soluble form, the MAC or SFC is a potent pro-inflammatory mediator. So the soluble form is very important. Okay. MCQ. It's not insoluble form. The soluble form of C5b9 is a potent pro-inflammatory mediator. So in that, the C5 activation is very important. The C5 activation step is very important. Okay. So many drugs will inhibit this pathway. That is the only one of the drug that already is called anti-CD5 antibody. That is eculizumab. This is the MCQ, important MCQ. So eculizumab is anti-CD5 already approved by US FDA. Anti-CD5 antibody is mainly used in PNH, atypical hemolytic uremic syndrome. Okay, and it's used as off-label from neuropathies to transplant medicines. So on-label, FDA approved for PNH and AHUS, but is used as off-label in neuropathies and transplant. Okay, so eculizumab is very important. This is about the complement. Then we'll go to the adaptive immunity. So adaptive immunity have two immunities. You know, one is humoral and another one is cell-mediated. Okay, in that they're telling that the main cytokine involved in this adaptive immunity is IL-2. Remember that much is enough. And the humoral immune response. The humoral immune response is nothing but attacking the pathogens via forming immunoglobulins. Okay, it's main cell involved in the humoral immune response, B cell. Okay, here there is no MCH. That is MCQ. The MSC molecules are not present in humoral immune response. Okay, in the humoral immune response, the main mediators involved is called PCR. That is B cell receptors. Okay, like MSC in cell-mediated immunity, the humoral immunity PCR is present. Okay, remember that much enough. Okay, and the main cell involved in humoral immunity is CD4 helper T cell. So next come this our immunity is finished. Okay, main part is finished. Then we come to our nervous system and immunity. So nervous system and immunity, what they are telling is, so multiple pattern recognition receptors have been found to express in directly on neurons. Okay, this is MCQ. So what are the pattern recognition receptors present in the neurons? The three. One is a TLR, and second is a TNF-R1, and the third is IL-1R. Okay, interlinking on TLR, TNF-1, TNF-R1, and IL-1R. And there is two pathways are present. For the nervous system, there are two pathways are present. One is inflammatory reflex arc via cholinergic pathway, and the second one is HPA axis and the glucocorticoid secretion. So HPA means hypothalamic pituitary adrenal axis. Okay, these two axes are present. One is inflammatory reflex arc, and another one is HPA axis. Yeah, these both are involved in the immune system. How they are relating to the immune system, we will see. In the inflammatory reflex arc, is similar to our reflex arc. One target will be there, afferent, central, efferent. Okay, like that only. In that, the afferent is mainly by the parasympathetic nerve. Mainly, the parasympathetic nerve is involved in this inflammatory reflex arc. Okay, so here they're telling that the primary parasympathetic nerve is no surprise, it plays a vital role in mediating the immune response. It is composed of 80% sensory fibers. So it goes to the center. The afferent will go to the center where it's called dorsal vagal complexes. Is comprised of three things: NTS, DMN, and the area prostima. Okay. After that, it will give the efferent. The efferent will be cholinergic. Okay. Because this parasympathetic is cholinergic only. So efferent will have this cholinergic effect. In that, they are telling that what are the neuroregulation of the innate immune response and what are the neurological response of the adaptive immune response. Okay, we have to see. So both the thing is when we are stimulating the nerve. The simple concept is when you are stimulating the nerve, the inflammation is decreased. Okay, both innate and acute immunity both are decreased whenever you are stimulating the nerve. Okay, that's why we have observed at the finally, but they are giving many mechanisms inside that one. If needed, you can read yourself. Okay, this unnecessary I'm thinking. Okay, and what the final thing they're telling is the function of this neural pathway. It impairs the function of the inflammasomes and overall decrease the transcription of pro-inflammatory cytokines. Okay, similar like adaptive immune system, they're telling that the neuroinflammatory reflex arc down regulates the humoral immune response system. Okay, so whenever you're stimulating this nerve, it will decrease the immune response. So next thing is the neuroendocrine system and inflammation. So this for this cytokines TNF alpha, IL-1, IL-6 exert at three levels of HPA axis. One is hypothalamus, anterior pituitary adrenal gland. We already know CRH will stimulate IACTH. The ACTH will stimulate the cortisol and releasing in the production of glucocorticoids. Okay, this cortisol negatively feedback on the hypothalamus and pituitary decrease the release of CRH and the ACTH. That negative feedback loop is already present. So finally, what is happening? It's a the decrease in the production of pro-inflammatory TNF alpha, IL-1, and IL-6. Whenever the cortisol is very much increased, it decreases the inflammatory response. That is the main thing. Okay. So what happening when we are giving glucocorticoids externally? So, okay. So chronic exposure to glucocorticoids, what happening? It acts like anti-inflammatory. So chronic exposure to glucocorticoid acts like anti-inflammatory, and acute exposure to high level of glucocorticoid increases the immune system. Okay, they enhances the immune system. Okay, chronic will act as an anti-inflammatory, and acute will act as a pro-inflammatory. Just remember. And here your MCQ. So here they're telling that SERPIN-A3. What is SERPIN-A3? So genomic microarray studies have suggested that dexamethasone and TNF alpha may have synergetic function. So cells co-treated with the dexamethasone TNF alpha exhibited a more robust secretion of pro-inflammatory acute phase protein, that is SERPIN-A3. So what are the acute phase protein involved in the glucocorticoid, dexamethasone, like that they are asking, then it is SERPIN-A3. Okay, remember the term SERPIN-A3. So then the other term is called SIRCI. What is CARCA? SIRCI. SIRCI is critical illness related corticosteroid insufficiency. So because of the corticosteroid insufficiency, the patient will get more illness. Okay, that is CARCA. There are many symptoms like delirium, refractory hypotension, elevated cardiac index. So this you remember what are the clinical features of CARCA, except they you can ask. So your cardiac index is elevated. Thus remember this is a crack here. Okay, elevated cardiac index and intolerance of internal nutrition, electrolyte imbalance, and persistent hypoxia. So among 70% of the chapter is finished. Then this inflammation and the critically ill. What are the in that they are dealing about the SIRS, CARS, okay, PACS. Okay, first we'll see about historical perspective not needed. In that they're telling that the sepsis syndrome is on further days it will become SIRS. Okay, it is replaced by SIRS. Okay, previously it was first sepsis syndrome. So SIRS we already know everyone. I don't repeat it. So SIRS is mainly the keyword is the SIRS was implicated in the orally informed response propagated by the innate immune system. So SIRS is mainly regulated by the innate immune system, but the CARS is primarily associated with the adaptive immune system and an attempt to return to the immune hemostasis. I already told. So this is, see here, this is your first event. Okay, any injury, tissue disruption, shock that is happening. Okay, it will increase your pro-inflammation. Okay, it is increase your pro-inflammation. This is your anti-inflammation. The pro-inflammation is happening. Okay, it will become, if it is increasing, it will become SIRS. Okay, if it is increasing more, it will become SIRS and it will recovery. Okay, okay. If it is not recovering, if it is still going, it will cause late recovery or death or PACS. Okay, and in between, if it is not at all decreasing, it's going up and it will cause MOF. This is the pattern they are showing here. Okay. Just remember, the first event is happening when the inflammation is little bit increasing. It will cause SIRS, and it comes down. It comes to early recovery. Okay, when it is not at all, it's whenever the inflammation is very heavy. Okay, then it will cause late recovery or death or PACS. The in between this process itself is going very high, and it's called multi-organ failure. Okay, so this yearly multi-organ failure. So you see the yearly multi-organ failure and on the pro-inflammatory side, but the late multi-organ failure is on the anti-inflammatory side. And this SIRS is the CARS only. The CARS is also in the anti-inflammatory side. The same similar process, if it happens in the anti-inflammatory side, then it is called as CARS and late MOF. Okay. Just remember these terms. Here we are reading about this in this SIRS, CARS, MOF, and the PACS. This only 4 topics are pending. So SIRS mainly innate immune system and CARS is adaptive immune system. Okay. And what are the MOF, multi-organ failure patients? How much the mortality rate? This MCQ 40 to 80% is the mortality rate. Okay. And this already has seen yearly mortality and the late mortality. 2 mortalities are there, yearly mortality and late mortality. So yearly mortality is mainly related to the single severe insult or series of amplifying insult. Okay. And the late mortality is attributed to the secondary nosocomial infection. See here. So whenever the nosocomial infection is happening, secondary nosocomial event is happening, that will cause late MOF. So late MOF is mainly related to the secondary nosocomial infection, and the yearly MOF is related to the any single event like this. Any one event, it may be injury, or it may be injury with tissue disruption, or injury with the shock. Anything. Okay. Next thing what they are telling is the same yearly mortality in MOF was attributed to SIRS, and late mortality is attributed to the CRS. In the diagram, is everything is depicting. And the patient who do not succumb to yearly MOF enter into the 2 pathways. Okay, if the patient will not go to the MOMF or any SIRS cards, then they will go to late recovery. That means that they will, if the patient is not going here also, then they will go at here only. Okay, either PACS. Okay, that is they are telling that here the persistent inflammation, immunosuppression, and the catabolism response. Okay. So what I'm trying to telling here is, suppose the patient is having the inflammation, if they have to go via this pathway, SIRS. Okay. If they're not going here also, they will go at here, PACS. Then we'll go to the SIRS. What is SIRS? So SIRS is governed by the innate immune response, first MCQ, innate immune response. So you're having multiple events like thrombosis, loss of loss of cellular polarity and leakage of the intercellular components. Okay, vasodilation is happening here. Not that much important. Okay, it is important to consider that in addition to the magnitude, so we have to know about cytokine storm. Okay, the cytokine storm is nothing but whenever some influx of cytokine and the guanine intermittent stimulants prompts the production of more cytokine through a series of positive feedback loops. This is called cytokine storm. So whenever more cytokine is formed, it can form a negative feedback loop to decrease the cytokine, but it's again increasing the cytokine. So this is called cytokine storm. Okay, in addition to the magnitude, it is important to consider that in addition to the magnitude of the inciting events, baseline patient factors such as chronic steroid use, malnutrition, and the age play a role in determining the adequacy of the initial inflammatory response. Okay, because of this, the cardiac index increases in response to reduced afterload. Okay, the cardiac index will be increases in response to a reduced afterload, and many therapies already in the market against anti-TNF antibody, recombinant IL-1RA, and recombinant protein C. Just remember this terms, this MCQ and cytokine storm you have to know in SARS. Okay. So, what are the factors determining the adequacy of initial inflammatory response? Okay, these three. One is chronic corticosteroid use, second is malnutrition, number is 3. This can ask the MCQ. Then CRS, when you go to CRS cause, so the cause represents SARS represents the overwhelming activation of the innate immune system, and the CRS can be described as suppression of the innate immune system. So whenever the immune system is very low, then only CRS is happening. Okay, here they're telling that anti-inflammatory IL-10 and IL-6 and the down regulation of the human regulatory antigen HLA-DR. Okay, so what are the cause has been tied to increase in IL-10 and IL-6, and it decreases HLA-DR. So what are the process has IL-10 is increased, IL-6 is increased. Okay, and it down regulates HLA-DR. Next thing is what are the leukocyte genes? Okay. Okay. So leukocyte genes, the expression of some leukocyte genes increased, including those genes involved in the innate immune response, such as TLR, NO2, haptoglobin. Okay, it's TLO, NOD receptors, and haptoglobin are the main genes involved in leukocytes genes. And another MCQ is persistent downregulation of HLA-DR associated with the MST2 receptors has been shown to increase the risk of development of infected pancreatic necrosis. Just to remember the term, so pancreatic necrosis, infected pancreatic necrosis is related to the downregulation of HLA-DR. Okay, we already saw here the cause is mainly involved in downregulation of HLA-DR. The same HLA-DR downregulation is happened, okay, and is associated with MST2 receptor, then it will be cause high risk for infected pancreatic necrosis. Okay, and what are the immunotherapies? Immunotherapies in sepsis, many immunotherapies are formed against these receptors, these interleukins. Okay, here the main thing is they're telling that one promised target therapy is formed against interferon gamma. Okay. But you remember these terms. Okay, and they're telling that whenever we are giving drug which is targeting interferon gamma, it is having more productive effect. Okay, in the overall improve the expression of HLA-DR among critically ill patients. Okay, no need to go in much deep interior. Okay, just remember one promising drug IFN gamma. Okay, it is involved in overexpression of HLA-DR. Okay, the down regulation of HLA-DR is very much problem. The overexpression of HLA-DR is good in case of critically ill patients. And these are the other MCQs. What are the 3 diagnostic gene expression in microarrays? One is sepsis metascro. Second one, FIM3 is to PLA-C8 ratio, and the number 3 is septicide level. Okay, these are another MCQ. And another one is multi-organ failure. We already saw yearly late multi-organ failure. No need to read anything. Okay, here they're telling that what are the risk factors for the development of MOF? Next MCQ. The risk factor for the development of MOF is abdominal compartment syndrome, yearly requirement of blood products, transfusion, and the infection. Very much important. They can definitely ask what are the risk factors for the development of MOF, including these 3. Okay, and the other risk factors. What are the other risk factors is advanced age, increased BMI, male sex, injury in severity score, and the base deficient on admission. Okay, these are the other factors. Okay, among that, which is the strongest MOF risk factor. See, having the strongest MOF risk factor is yearly transfusion requirement. So yearly transfusion requirement is the strongest risk factor for MOF. Okay, yearly transfusion requirement. Okay, just remember one MCQ. And again, another MCQs are male sex confers a greater risk of developing MOF, and female developing greater risk of death. So male having more risk for developing MOF, but the female having more risk of death. Okay. Remember, everything is MCQ. Very important area. Okay, MOF. And another scoring system, they are telling that the Denver scoring system. Okay, this is also involved in identify the high risk patient and its strongest association with the yearly trauma mortality. This much only. And we can see about this one, ICS. Okay, so PICS. PICS is persistent inflammation, immunosuppression, catabolism syndrome. Okay, what is the main things involved in here is the mechanism of this PL16 based on pathophysiological maintenance of the low-grade inflammation with the increased serum level of IL-6 and neutrophils in conjugation with immunosuppressants through lymphocyte depletion dysfunctions. So main cytokines involved in IL-16 and 17. Okay. And the main thing here they are told that so this diagram itself depicting this PICS actually. Okay, so whenever any insult is happening, acute or chronic condition, anything is happening, it will stimulate our bone marrow, stimulate hematopoietic stem cells to increase the neutrophil that cells. Okay, cells in the bloods. Okay, okay, whenever okay that is there happening, this HSC will go into the MDSC. MDSC means myelodysplastic, myeloid-derived suppressor cells. This is called MDSC. The myeloid-derived suppressor cell is, so this HSC is will form okay every cells. Okay, but this MDSC will only form myeloid-derived. Okay, so that is the things. It will go on the cycle. It's a vicious cycle. Okay, it will go on. Okay, whenever HSC will getting that dysfunctional myelophysis, okay, then it will go to the MDSC stages. When the MDSC is having continuous low-grade inflammation, then it will go to the HSC. Okay, these are the continuous cycles. So what are the factors is decreasing the cycle? Okay, when exercise, propranolol, nutrition, anti-inflammatory medication, anabolics will reverse this continuous low-grade inflammation, and it will block the cycle. Similarly, that mRNA and erythropoietin and all block this cycle. Okay. Similarly, this MDSC phase is blocked by the anti-PD-L1 erythropoietin. Okay, this is not another name in the theory, not given in the theory. It's just a diagrammatic review only. So whenever some chronic critical illness is happening, if it is not recovered, it will go to PICS. Later, it will go to death. Or whenever the cycle itself happening, whenever the inflammation is happening, it directly go to the death also. Okay, but the inflammation will not directly go to the PICS. Okay, it will go via chronic critical illness. After that only it will go to PICS. So a little bit about PICS. Okay, in that what they're mainly telling is so clinically, in every PICS, any chronic illness, muscle wasting will be there. Clinically, this manifests as severe muscle wasting and cachexia. In a matter of weeks, patient can lose up to 30% of their clean muscle mass. Okay. So, what are the therapies? What they are telling is how much protein supplementation is needed in critically ill patients. Now the value is 2 kilogram per kilogram, 2 gram per kilogram body weight. Okay. 2 gram per kilogram body weight is a protein requirement. Just remember. Okay, that's it. We finished. Okay. Only thing I have missed is this chart. Okay. This chart I not able to this one consolidate it. Okay. Just to take a screenshot. Already in the book only. I am not able to consolidate. We have to read only. Okay, no other way. Somehow we have to read only. Just take the screenshot. It's a self-explanatory only. We could not say anything. Okay. They can ask question if possible. Okay. Not compulsory. Okay, that's it.
Yeah, nice.
Thank you.
20th
It's actually boring topic.
21st
It's a boring topic
different, na?
only.
It's a very.
This is 21st
The
edition.
topic is very.
Vague topic only. Okay, we'll see. It's actually I had it from the 21st edition. Okay. Hello?
Yes.
Tomorrow? Tomorrow the class is taken by this one. Guru Praveen will take. Okay, thank you.
Okay.
Thank you. We'll see. Bye.
Thank you. Nice class.
Thank you.
Nice class.
Bye bye.
Bye.